Every moment I see a patient, I don't see it as a burden. I always see that I'm helping my mom right there. And that pushes me, and it has pushed me for many years now. So I lost my mother to cancer. That was 1998. I was still very young. So that inspired me to do, medical related or health related subject in high school. And I'd say God probably saw me and what I wanted and blessed me, and I got good grades, and then I chose medicine. In my cancer journey or career, I found out, I mean, every cancer patient suffers, but we were having aggressive diseases that affect the gastrointestinal tract, and very young, coming in very young. So it's it's really made me to think of further specializing into the field to see how I can help those patients. But of course, even other sites, I would say, are interesting sites, but I chose to do gastrointestinal tract. Yeah. My name is Fidel Wagumya. I'm a medical doctor by training, and also I work as a consultant oncologist at the Rwanda Military Teaching Hospital, at the cancer center, the Rwanda Cancer Center there. I've been working there for since 2019 as a specialist. But in that line, I do subspecialize in what we call gastrointestinal cancers. So managing cancers of the GI tract, where the food goes and passes all the way. And I also happen to be a teacher. I am an academician. I have a role in teaching the future oncologists, but also the future doctors in general. So I also work at as a lecturer, as a senior lecturer at the University of Rwanda. But I also have other affiliation with other universities, both local and also global. I finished medical school in 2013. And then, so in medical school we do 6 years of training in Rwanda. So I trained in Rwanda at the University of Rwanda, and then did 1 year of internship at the Butaro Hospital in the Northern Province. And after that, I also worked 1 year there as a medical officer, then went for training, for cancer training in Tanzania, Dar es Salaam, where I did 3 years of oncology training, what we call residency in medical terms. And after that, I came to Rwanda, started practicing since, as I said, 2019. And then after about 2021, that's when I went back now to subspecialize in what I would call what is called gastrointestinal tract. And that's when I came back in 2023 from Canada. That's where I did my training for about 2 years. And since 2023, I came back as a subspecialist and been working there since then. So that's my journey of medical practice. So the interest to do medicine and also further to do what I'm doing now as a medical and radiation oncologist is that it's a personal story. Personal story in a sense that so I lost my mother to cancer. That was 1998. I was still very young. Actually hadn't even completed my primary school. So, but I saw the experience she went through, because I could, the visit between hospitals and coming back home, I was young, but I could see that. And that really inspired me to and then I lost her. So that inspired me to do, medical related or health related subject in high school. And I'd say God probably saw me and what I wanted and blessed me, and I got good grades, and then I chose medicine. So it wasn't until I was in medical school in my fourth year and entering fifth year that I came to know that my mom actually passed on because of cancer. So I checked in the records of the hospital where she passed on, where she got treated, because she passed on from home. Actually, back then it was not easy to access even hospitals easily. So I checked the records of the hospital when I was doing my training there. One of the hospitals we were training in, and that's when I came to know that she passed on because of cancer. And back then I actually didn't know that I was going to do oncology or cancer medicine. I was really into surgery, and if you ask my colleagues back in medical school, they will, even now, they ask me why. For those who don't know the story, so maybe some of them are going to know because I've just shared. They always want to know why I changed my mind, didn't go to do surgery. So that was the reason. So I realized when I was in my fourth year to fifth year, and then decided to do oncology straight. In my cancer journey or career, I found out, I mean, every cancer patient suffers, but we were having aggressive diseases that affect the gastrointestinal tract, and very young, coming in very young. So it's it really made me to think of further specializing into the field to see how I can help those patients. But of course, even other sites, I would say, are interesting sites. But I chose to do gastrointestinal tract. Yeah. I mean, even now I see it. There are some patients. I mean, some patients who come to us and they don't want to share the pain they are going through with their kids, but also with their relatives, and they do it to thinking they're protecting the kids or the relatives, but in actual sense, what happens is this kid or these kids or the relatives, when they come out to know it after, it actually affects them. So sometimes, I mean, I was young, I was 11 back then, and probably even looking back, if you told me mom had cancer, probably it didn't change anything. But at least when you grow up and then you remember that your mom shared their pain and their fears, the connection comes back even if she's not there. So what I would tell probably those who are affected now is, your kids are your core. I know that these days there's some families that don't even talk, but for those that have, those that talk, please share, because it affects them anyways. Whether you share or you don't, it will affect them. Then, if it's not done, it does affect them now, it will in the future. So I see it how my patients are affected. I see the pain they go through. Right now we actually have ways to treat the pain. Back then nothing really was there. Treatment in the country was non-existent for the disease that she had. So I see how painful it was to have that experience without support, family support. My dad was there, my elder sister was there. They were, the ones that were helping her. But I see that if you don't share and then you go through that alone, itself is another disease you're adding on. And then when those who could have helped if they had known come to realize that when you're no longer there, or maybe even if you're there and you're cured, it's painful because you feel like you were not helpful to your mom or to your other parents or to your other relative. My book, Beyond Cancer, is inspired from my experience, my personal experience as well. The fact that when I grew up, I didn't have much story about my mom. My father didn't share. My sister, I would say, was still in pain of the loss, and even subsequently, she never shared for many reasons. So for that reason, I felt like there is a story that is not talked about, but I made it really personal to actually search for all the stories, like how did she experience the pain, which hospital she went to, which traditional healers she went to, because back then that was the norm as well. So I asked all these questions because I knew that there is a story, because I see how my other patients now live their cancer journey. So I wrote down that as my own, for my own, I would say, experience and future, coming back to it in the future. And then when I started cancer practice, stories could come, stories that in medical school, honestly, when you're still a student, you don't have that experience. But when I started practicing, the stories were really brutal, I would say. Really, really tough stories to hear from patients of all ages. Back when I was a general practitioner, I was seeing all sorts of patients from 1 year old to 80 old or 90 old, and the stories were different because of the age, but also similar in the sense of how cancer affects patients and their families. And I was like, maybe I should start. So some of them I would come back to people that I was working with who were not in medicine, and I would tell them, medicine is a school. You learn a lot. You learn psychology, you learn how to manage people, you learn relationships, you learn economics, because there are people who could come there and say, am I going to sell my house so that I can continue treatment? So all those stories, I could close the door for one patient, the next to come and cry within, so that patient don't see me in the next patient. But there were tough stories to assimilate, and made me want to continue to write, so that I know that some of them are not going to speak, and that's why in Beyond Cancer, my book, I don't actually share their names, because I know that people don't want to share some of these stories of their darkest moments. And so I wanted to give them the voice, give my mom the voice, give my sister, who is one of those who are affected by cancer, to give her a voice that she never shared with anyone, but this time she accepted to share. So one of the story there is my sister's story, where she shares her personal experience, but also the experience she had with my mom. So it's not easy, but I would say actually that on our side as oncologists, we are somehow on that side. We're somehow lucky, because most of the time patients come to us when they have already been told about the diagnosis. In few incidences that we do break up the news, being the first one to break the news, those are tough moments. One is, there are some people that still think cancer is a death sentence. So when you say you have cancer, they see their future shattered. If they have parents, they are thinking they are leaving before their parents. If these are parents who have kids, they are leaving before they see their kids getting married or other achievements. So it's tough moment during that moment when you're giving the diagnosis. But you try, by training, by experience, you try to tease out what the patient knows about whatever brought them to the hospital, and then you tease out whether they have had anyone talking about the diagnosis and what it could be. Once you identify where the patient is, then it's that moment when you say, you know, unfortunately you have got this disease. Cancer is, we talk about cancer, but cancer is many diseases. When it affects the breast, it's breast cancer. When it affects, even within the breast cancer, we have many types. So I would say it's not an easy task to break up, to break the news of cancer diagnosis, but it doesn't end there. It's not like you're going to say you have cancer and that's it. No, you start there. Actually, some of studies show that the amount of information given during the consultation when you're breaking the bad news, 80% of that stays in that room. So the patient doesn't go with that because of, you know, emotions and all that. So the next day, the next visit, you add on other things. You have cancer, but this is the stage, it is still early, you can treat it, it can be cured if we do this and do this. And even for those that have the terminal disease, stage 4, which is not curable, we also tell them, you know, you have this stage, stage 4, it can be treated like this, you can live longer if we get the treatment. So those, you share all those, but also depending on the patient literacy. There are some patients who tell you, I don't want to hear. If they really know much about the disease. There are others who tell you, doctor, whatever you want to do, do it. So it depends on the patient as well. But it's an art. You learn it as you grow in the field. Not all cancers are, actually many of cancers are not inherited. It's not like family, they're not inherited. But we do have some that are inherited. Like breast cancer, some of the gastrointestinal cancers as well. But majority of cancers are really, they come by bad luck, I would say. So why has it increased? One, I agree it has increased, but also the knowledge to detect, the equipment that we use to detect, we have also improved in those areas. Back, you know, I don't know, 30 years ago, you could die of cancer without knowing that it was cancer. So the numbers were low because we were not able to detect back then. The knowledge of physicians and surgeons and others were not that great. But also we have also changed the way we live. There are a lot of other risk factors that we are, you know, dealing with in daily basis. You know, alcohol consumption is, you know, has gone so high. The numbers in Rwanda every year are increasing. If we don't do much, really, we are going to see a lot of cancers that are related to alcohol. Tobacco, the kind of food we eat, the lifestyle we live in. We don't exercise. People, you know, are seated because of work most of the hours. So those lifestyle have also changed compared to the previous year. So as those risk factors increase, and also we have viruses that we deal with that also are linked to cancers. So those are some of the things that have increased, hence increasing the number of cancers. But we also have cancers that are, you know, purely bad luck, because in our body, as we even now seated, the cancer cells are going through what we call divisions, or in layman you can say multiplication, but it's cancer reproducing them. I mean, sorry, cells, natural normal cells reproducing themselves. During that process, there are some that get damaged, and they are not cleaned by our body natural process, and that causes cancer. That's what you will hear people say, mutations cause cancer, and those are really things that happen with no, some happen because of those risk factors, others happen just because of bad luck. the thinking of that a person dies because of witchcraft, I would say that it is reducing, because the government of Rwanda, I'm talking about in the Rwanda context, has really done a great job in decentralizing the healthcare access. So we have the health posts, we have health centers, we have district hospitals, we have provincial hospitals, we have level 2 teaching hospitals, and then at the top we have the university teaching hospitals. And all these really increases access to care. And because of that, every patient nowadays, every person who gets sick, at least I would say majority will go to the hospital, which was not the case back then, because there were no hospitals in the village or the district. So the number of people who believe that every disease or every symptoms, every ailment is witchcraft has gone down. But we still have some. We get patients. Actually, one of the factor that leads to the fact that we see patients at the late stage is because they believe it's witchcraft, or they go first to the traditional healers. They try whatever they have, and then when they fail, they send you to the hospital. The numbers are now few, but they're still there. Right now, in terms of insurance support, right now, I think the latest numbers of coverage is in 90%, around there, 90% of the Mutuelle de Santé covering the whole population. And that means that patients are able to afford, at least from a person getting sick to starting the cancer treatment, that is all covered by the insurance. And that is a huge, reduction on the pressure, economic pressure that a patient usually has to go through. And then when it comes to the cancer treatment itself, the government has also done a great job in that. Right now, for cancer diagnosis, majority of referral hospitals that we have are able to do that. We have CT scans everywhere in the teaching hospitals, but also in other provincial hospitals. We have also those CT scans. And then in terms of the actual cancer treatment, which is either surgery, chemotherapy, or radiation, surgeries, majority of surgeries for cancer can be done in all major referral hospitals in Rwanda. We have 5 now, in Butare, CHK, King Faisal, and Rwanda Military Teaching Hospital, and then Butaro. They can also do surgeries, some surgeries there. And then chemo still in those hospitals, except CHUB, which is also starting soon. And previously, and then radiation center, which is at the Rwanda Military Teaching Hospital. Previously, we could not, the patients who are on Mutuelle could only get chemo from Butaro, because it was given with support from an NGO. But right now, as you might have heard, the government has already approved that also cancer medicine go on the Mutuelle de Santé package. So that is going to, I think I'm not up there, but I know there's some of the information that the drugs are already in the procurement process, and soon patients are going to get benefit that. So that is also a relief to patients who have been, dealing with, some of the journey going to Butaro, but also some paying out of pocket because they can't go to Butaro. Yeah. It's not about the disease itself, it's the human part of the disease. You see a patient, actually one now that I remember is wasn't Rwandan, though the book talks about Rwandan experiences, but I was still in training. And this gentleman came, as you can imagine, I was still in training, so there are things that I had not seen in my life of practice. So this gentleman came with a disease, it's called sarcoma, but this sarcoma had taken the whole part of the face. Like the only thing you could see is just a piece of the mouth that was left, and the rest of it was just a wound. That gentleman was coming far away from part of the Tanzania, far away from Dar es Salaam, where I was doing my training, and he was alone. We call it a rounding. We rounded on him when he couldn't even tell who is the doctor. That is because he couldn't see. The tumor had eaten almost all his face and the scalp as well. The only treatment that we could give him that time was chemotherapy. It's drugs we inject in the blood system. We gave it to him, but it didn't help. It didn't help. Because it was my first experience to see such disease and how it affected the face, it affected me. It affected me in a sense that I was in my first year of training. I had treated patients at Butaro, so I had some experience, actually more than my colleagues. But I was like, is this really what I want to go through for the rest of my career? One, because actually that disease, it's only that in Tanzania we could not get the actual good cancer drugs that are needed, but in other countries they could actually treat him with some good success. So it made me ask myself whether I should continue training or I should not. We tried several regimens that we could get in Dar es Salaam. If I recall well, probably from the start when we started treating him, it didn't last probably 3 months. Not more than 3 months with the trial of the drugs that we could give, which we knew for sure they were suboptimal. As a trainee, one, of course, you don't take up such big responsibility, but I'm sure even if I had finished my training in first year, I might not have told him that you're left with a few years or a few months or a few days. If you ask me today, I do. I do because that's what actually we should be doing. But of course, the kind of communication is what probably differs from one person to another. There are some physicians who would, as we are different in nature, say you're left with 3 days. Though these things of saying you're left with what is not for us to determine. What we usually say are statistics that we know from research, but we know that they are sometimes wrong. There's some experiences where you tell someone, if you're not careful, you tell someone you're left with 6 months because that's what the studies show, and this person live on for years because we are not God. But with experience, you know the range of what the disease and science says, and then the rest you say, it's up to God. We want you to live for long. These are what the studies say, and but we know for sure that we are not the ones to determine one's life. But you tell them so that at least for what you know, what the facts, what the evidence says, so that if they have things to sort, they sort them. If it's to get themselves in line with God, or whatever spirit or spiritual alignment they have, to do so with clarity, and also you support along that journey. You see, treatment of cancer is treating the cancer cells, but the human body where the cancer is also needs treatment. I'm actually having this interview from a clinic. I'm from a clinic. I was just consulting patients, and this patient came today, and he comes from far away. I think she told me she lives in the west. I won't mention the district. We asked them, so when we finish treatment, we asked them that they come back to see us so that we check. So usually cancer, if it is to come, it comes within the first 2 years. That's by experience, by research. So we tell them that come to us every 3 months for the first 2 years, and then we extend to 6 months, then once a year till the 5th year. When we say, you're declared to go, we are done with the cancer that we are treating. It has not come back and we are good. So this woman came from West. We had treated her about 3 months ago and finished her treatment. But even finishing that treatment was a struggle. So today I kind of had a little bit of time, so we had a chat, and so she told me the experience of how she was. So when we are giving them treatment, the radiation, they stay here for 30 days, about 30 days or more, depending. And we don't put them in the hospital because they are not very sick to be hospitalized. So they have to look for places where they live around here. So this lady came. One of the NGO actually support them to get where they are accommodated, but sometimes it's full. So she spent the whole 30 days of treatment sleeping on the floor, on the patient, on the hospital floor. Sometimes also going around, and this experience, and because she doesn't have a relative in Kigali, and she comes from far, so that was experience. So even coming back for our follow-up, because of money, sometimes, so she didn't come on time because she couldn't get. Then I asked, so one of the assessment to see whether the disease has gone is we repeat some of the imaging to see whether it has gone. So she told me, doctor, I am left with only 500. So if you ask me to go to do the exams, A, B, C, D, blood and CT scans and MRI, I'm not going to get that. So these are patients you ask for much that they don't have in terms of cash. And I would go on and tell you how many patients probably we have left because of the means. Lucky enough, now we are, as a country, we are getting better in terms of what we can cover. But the Mutuelle de Santé covers only 90%, so the 10% patients have to do it by themselves. But I would say for cancer treatment, it should be 100% coverage because even additional 10,000, 20,000 means that this patient might not eat for a long time. Yeah. So there are many stories that you go back and say not only it came to a wrong person because of the capacity, but probably we could do better. Yeah, so my mental health, or our mental health in general as oncologists, is as a physician, honestly, at large, probably for us, because we deal with the sick patients most of the time, is something that I would say we ignore. As general public also ignore it, because I think it's not necessarily people who are dealing with patients should care for their mental health, but in general, we should care about our mental health. But us in particular, I would really say we should. The whole experience really affects you. Whether you know it or you don't know it, it does affect you mentally. There are some people that it affects and they shut off and they become bad physicians. There are some people it affects and leave the practice. Uh, and there are some people that are affected, and you see it in the practice actually, like they're affected. So I would say we are not, there is no, in Rwanda we still have even few people to help us in terms of psychologists or psychiatrists or so there are still few, but even us, the practice of seeking the support is not there. So most of the time it's personal move that you do, and you go to seek help to a therapist, or you find other ways to deal with the toll, the emotional toll that it brings on you. But there's really no much other support that we get. If you ask me how I do it, number one is, you have to love the work that you do. If you don't, honestly, you won't last. If you push yourself to last longer, then you become a bad doctor. So myself, I thank my mom because every moment I see a patient, I don't see it as a burden. I always see that I'm helping my mom right there, and that pushes me, and it has pushed me for many years now. But apart from that, I am lucky now to have a family that when I go to, it helps me relieve some of those. First few years of my marriage, I shared with my wife and came to realize that she was actually taking it, and I stopped.
It was too heavy for her.
Yeah, so I stopped to share much of experiences. So now I come and we find other ways to release, and then I do evening walks. Lucky to have the good environment that we do that. I love it. I watch movies. I follow football, and that helps me. But I think also being open about it. For me, if you ask my patients, my friends, because we actually spend more time with them, so it's not too much on me dealing with it, but it can take a toll on you. But my mom really is the one that pushes me to continue to do what I'm doing even now. Yeah, I'm married with one wife, and I have 3 kids, a daughter and 2 boys. And what I do for fun is already what I shared. I love watching football, movies as well. Time is limited because of all this, but I do get at least 1 movie a weekend or a series to watch, and I also weekends football is when it's there. But we have Champions League going on. I do that, and then as I said, I love walking. So that's what I do for leisure. So about the book is already launched, and it's available in major bookstore in Kigali, but also we are trying to reach out to other bookstores, libraries in the provinces, but it's also available online at Amazon, and in the near future we are trying to have it as an audiobook, and people will get it where they get other audiobooks, whether Audible or other platforms as well. When I was writing the book, the intention was really to share patient stories, because I know that they don't share. My next actually task now, after this is released, so this book has been a long journey in making. As I shared, I started with my own mother story written down, but as I was also in training, but also after training, I could write a few of these stories. we also did interviews to get other stories that usually I don't get time to get in the consultation of 15 or whatever 10 minutes that we have. So the book in itself, in writing, took me about almost a year, I would say. But some of the stories were, stories that I wrote down some times back. But because of many other tasks that I'm involved in, it took me almost a year to put everything together. So when I was writing it, I wanted to share patient stories, but because I know for sure some of them could not share their stories, and show kind of address cancer and show the other image of cancer that people outside or who don't have experience don't know. But I also wanted to raise awareness that in some of these stories you will see stories of success where we treated cancer, cured, patients are still alive and they're achieving and doing life. We share stories of courage, and that's why we say beyond cancer there's other things to do. There's life to live, there's families to make, and other achievements, and I hope that for the readers they're going to get that from the stories of patients that they are sharing, that you see courage, you see love, you see relationships, you will see, but also that other part of cancer that we usually know that is suffering. But I hope that it gives the dignity patients deserve, whether live or passed on. And I hope that whoever reads it connect with cancer patient and be there for them when they have anyone close to them in their lives. So I was lucky to get a scholarship from an American organization. It's called ASCO, the American Society of Clinical Oncologists. And so I went there for 18 months, close to 2 years. I was trained by experts in the field, and then time came when I had to go back, and the hospital where I was working and my supervisor really wanted me to stay and work from there, but I felt I had a duty. Back then we were only 3 oncologists in the country. If I had left, I don't know how they could have managed, but that's not the case. But also, there's really something. I've trained in many countries, in Africa, Tanzania, Ghana, Botswana. I did several rotations there, but also in the US and Canada. I've treated patients in those other countries, but there's nothing really that come close to helping your person, I would say. Someone from the same country, someone who speaks the same language, share the same background, and knowing that I'm contributing to the lives and also to the country, my country, was one of the reasons that I never really thought of staying in Canada, and it's something that I will. Even now, people ask me that, why did you come back? Why didn't you stay there? Why did you come back in places where you know that care might not improve in the next decades? But the reason was really to contribute to my country in my own capacity, which I'm doing now. So after I finish my training, I am also, as I said, a lecturer in the university, and I helped to start the only medical oncology fellowship program in the country, and one of the few in the region. And right now we have 7 trainees that are going to graduate first cohort this year in April, and another cohort end of next year. There will be 7 other oncologists trained in the country. So that to me is something I couldn't have done if I stayed in Canada, and other things that we're doing. Yeah. So the message for those who go to train and stay, actually, so so there's evidence that one of the factors for brain drain is to train outside. And for me, I will go in line with the government's line in this. People will go for green pastures, but even if you go and you stay, remember your home country. There are many ways to contribute to country. You can contribute when you're there, you can contribute when you're outside, as long as you don't forget your country. I would say people go. We know people who have gone, and after 5 years or 10 years, they come back and they continue to support their country. So it's not about, of course, if you know that there's a shortage in your field, probably you're called not to abandon your colleagues, I would say. But if you've decided to go, don't forget what you have left behind in terms of what you can afford to support them. Yeah, so the numbers of oncologists in Rwanda are still few, but I would say that it's really the progress we have had for the last even 5 years only is amazing, because 2018 when I graduated with my colleague, because we came 2 of us, we found only one of our senior in the country. So in 2019 we were only 3 oncologists. Right now we are counting 15 Rwandese oncologists, and also we have our other experts that are in the country as well. So far we have 3 of them, and as I said, we are training other cohorts. So we're going to have 7 others in the next 2 years, and this is in the field of medical and radiation oncology. But we have other colleagues who are trained in surgical oncology, pediatric oncology, gyne oncology, those other subspecialties. So we have them there. So the numbers have really increased. And it's not really only in oncology. If you inquire from surgery, the numbers back in 5 years were few. So it's a general shortage in general in Rwanda, but also in other countries. And the government is actually working on that, not probably talking on behalf of the Ministry of Health, but there's an initiative called 4x4, where they are trying to quadruple the number of healthcare providers in general, clinicians, nurses, allied, and I think they are doing tremendous work actually since the initiative started. And I hope that that same quadrupling is going to happen in oncology as well, and I am seeing it. In terms of the question of the longevity of the training, that's in any medicine, whether you're in oncology. There are actually others that are way beyond us. If you ask someone who is studying neurosurgery, it's even longer than us. We might actually be one of the people that are doing shorter trainings. So it's a general thing in medicine. That's why we call it a calling. You can't do it without having that calling, for sure. Would I want my kids to do the same? Yes. Will I ask them to do it? No. I hope I'll be a good role model that they can emulate, but I will support them in the way they want to go, whether it's medicine, whether it's engineering, whether it's I don't know, whatever they want to do. But my only role and my pattern's role is to create a way for them to make their own wishes and careers. As as I shared, no one really except that the bad luck came into my life very early, and it guided me. But otherwise, I think the same. I will let my kids decide, but I only create an environment for them to choose what they want to do. Yes, should we expect another book? I promise you, the next time we meet, I don't know when, but sooner. Another task I have is to share oncologist side of dealing with cancer. And this time, we are only few in Rwanda, so I intend to include my colleagues on the continent, mostly in Sub-Saharan Africa, to share with us the experience with cancer as a physician. And that is on the horizon for sure soon, should be coming out. In terms of research, one thing I forgot is that other than being a clinician and academician, I'm also a researcher. True, we are still lagging behind in terms of research in Rwanda in cancer. It's a new field. It's a new field, and new fields really take time to get to the top. And but we are doing our best. If you look at the number of publications coming from Rwanda on cancer since 2012, when Butalo started, the number increases every year, and we hope that it's not about the numbers but the quality of the research that we're producing. So our trainees, we ask them to do research, and this research should be published so that people know what we are doing.